Okay. Good morning to you all. Can all of you please switch on your cameras and focus on your lovely faces? Thank you. Right. Okay. So, how was your exam? Anyway, first of all, some of you may be knowing about myself. I'm Dr. Vasanta Disera, VOG. Currently, I'm working in base hospital Walasmulla. You know where's Walasmulla is? Walasmulla, in Sri Lanka. Yeah, it's closer to Mathura, right? So, right. And I have been a ERPM teacher for a long time now, for a long time. Yes. So, we'll first have a chat about your exam, the last exam. How was it? Was it good, bad, average? Right? It was not a bad paper, to be honest, right? Like average kind of. That is kind of the standard that you get because you won't expect all the questions, like very simple questions. There are some advanced questions and there are very easy questions and majority are in between. If you take a curve, right, standard curve, it's most of the questions comes in the middle, the center. So anyway, you'll be getting your results in recent future, right? So today we are going to discuss about, as an introductory lecture, I'm going to discuss with you all regarding this OSCE setup and as far as the obs and gynae is concerned, what are these OSCEs and maybe new to you all, right? You would have done MCQs, SBAs and all these things, but now they have changed the curriculum. You all are aware about it, right? So when it comes to these OSCEs, previously there are some students who are going to take the old format of exam also this time, and there are students who are going to take the OSCE setup as the first comers, right? So for both categories I'm talking, right? So previously you had, if you take obs and gynae, you had once you complete your theory part, then you are eligible for your Viva exam. In the Viva exam, three main components. There is a emergency component, and there is one obstetric long case and one obstetric gynae case. There were no short cases. Now they have removed all these long cases. We had long cases, 2 long cases that you have to do, but now no longer for the new students, no longer they will be having these long cases, right? Instead, that you will get 3 OSCE stations for obs and gynae. 3 OSCE stations. So if you analyze broadly, these 3 OSCE stations, they will be mainly concentrating. One OSCE station will be allocated to obstetrics. One would be allocated to gynae, and one would be like, the procedures, instruments, right? The pictures, diagnosis, spot diagnosis, and that kind of the setup. So usually for obs and gynae, as far as the obs and gynae concerned, what I can predict is, and I had some chat with my colleagues also, right, who are going to, become examiners in your OSCE. So they also had that kind of idea, right? So probably one would be allocated to obstetric, one would be allocated to gynae, and one would be like, emergencies and instruments and the demonstrations and all, right? Breech delivery, sometimes you make it, right? So what is the main difference between this OSCE and your previous good olden days cases-wise examination, right? So when you have this cases-wise examination, there was one main problem was the examiner factor. It was had a significant impact on the students' performance and the markings that you are going to get. Because there are actually some students are very, reasonable. You can talk with them, you can negotiate your answers, you can, that kind of categories were there. Majority are like that. And there were some examiners, they are very rude, like, they want their own answer. What they are thinking, you have to give that the same verdict, but that is not practically possible. So there were some students who were benefited because if you go to a good examiner, so-called good, like, for a reasonable person, right, the chance that you are passing the exam is high. Whereas if you're going to a who is called like, a difficult customer, right? Then your failing chance is high. So that unfairness was there with the previous examinations. Probably that's why they have gone into this OSCE. In OSCE, it's usually not examiner dependent. Most of the stages, you will not see an examiner, right? So, because there will be set of questions, right? If you take, for example, PPH, right? There will be well-formed questions written on a piece of paper, or there will be some person who is asking those same question. Suppose if you take PPH and there are 10 questions, all 200 or 300 students will get the same 10 questions, not beyond that scope. So that is fair in a way, isn't it? So because I mean, if I'm a examiner, right, I can ask some questions from one student, different set of questions from another student. Okay, that unfairness is no longer there because it is OSCE. Because OSCE, all the questions and the instructions are clearly written. You have to follow those instructions. Okay, so that unfairness is not there with OSCE. What is the disadvantage of these OSCEs? And there's another advantage of OSCE is now clinical exams, previous like, all pattern, all type of exams, you have to perform in front of an examiner, right? That is very distressful. That's very stressful actually, right? Because, performing in front of a senior is anyway going to be stressful, right? So in the exam, you are under stress. So if you have to do your what kind of bulls and all, right, in front of an examiner, then you'll be more stressful. But that stress is very minimal when you come to the OSCEs. Okay, because the examiners are not going to, question you directly. So in that case, that stress is low. So what is the disadvantage of these OSCEs compared to the previous pattern? That is one of the main disadvantages. Usually students used to come to the ward and practice history taking an examination uh, with the old format. But now the amount that you have to spend on that, like the time that you have to spend on history taking, detailed examination and all, no needed. Because in the OSCEs, you won't be given like patients for a full examination, do the full obstetric examination or do the full gynae examination like that. Only if in case there will be only specific component like auscultate the fetal heart. The instruction will be like auscultate the fetal heart. So you have to select the pinard stethoscope, you have to position the patient, and you have to keep the pinard stethoscope in the proper way, and you have to remove the wristwatch and keep it on the patient's lap so that you can see it, right? And you have to do it in the proper way. You stabilize with your pinard, and once you stabilize, you take your hands off and try to listen. So there is a technique of listening to fetal heart rate. So that kind of a thing will be assessed. And definitely, vaginal examinations and the speculum examinations will not be coming in a live specimen. Like you won't get patients to perform vaginal examinations or speculum examination. Instead, if they have mannequins, right, sometimes you might get a chance to perform vaginal examination or speculum examination. That I will teach in the following sessions, right? So this is kind of an introductory lecture today, right? So the next week onwards, we'll be doing the course, right? There I will teach all in one part how to do this speculum examination and the instrument demonstration and all these things will be done in future, so you don't have to worry. So one of the most of this, the stress regarding this clinical examination previously, this vaginal examination and the speculum, but that part will be mostly eliminated in your OSCEs in case they might ask to do it on a mannequin. That is much easier than with a live patient. Okay, clear? And I don't think that practically, it will be assessed in your exam. Okay, so whatever it is, this is kind of the OSCE. And OSCE, you have 3 stations, and depending on the availability of time, they will allocate 12 to 15 minutes for a station. So you have to spend about, we'll say 15 minutes on a station, and that station, there will be 1 scenario or 2 scenarios given. Like if they want to assess 2 cases, 2 scenarios together, they will ask, okay, like PIH, and there will be a scenario regarding PIH, and there will be scenario regarding PPH. So there will be a paper and written instructions clearly and the questions. So you have to answer those questions. And there will be another station where you will have several instruments like vacuum devices, Kiwi cup, right? Remember, Kiwi cup is freely available. Kiwi cup, forceps, different types of forceps. You all know there are 3 types of forceps, right? And the simple instruments like, artery forceps and green arm tages, right? So you would have done those things. We did those things with the theory also, right? But we will do a demonstration during your course. Right? So there will be instruments like that, and they will be asking several questions. What are the advantages of this pelvic curve? What are the disadvantages of this thing? What is the advantage of having a long forceps compared to short one? And what is the name given for that? Right? What are the indications for forceps? What are the indications for vacuum? And what are the contraindications? Okay, those things will be assessed in your OSCEs. So OSCEs are basically, easier than the previous, the real, clinical exam with involving live patients. Sometimes you may get 1 or 2 live patients, just to give a history or, use some information, but most of the cases, you won't see live patients when it comes to the OSCEs. Sometimes you may, sometimes you may not. Okay. Right. Any questions so far? Have you got some idea, some understanding about what are these OSCEs and how are they going to perform, right? Okay. And again, it's going to be a business game with the time. So you have to, within that allocated time, there will be stations like 1 station, 2nd station, 3rd station, like that. There will be stations. So if you if you are running out of time, there is no place for you all to go back and answer the previous station because people are moving. So you will be going to the station A, and after 15 minutes you will be moving to the station B, and another person will be coming to station A. So you are not allowed to go back and refill whatever the answers. So you are doomed then and there. Okay, when you are doing ASCIIs, especially for medical terms, they will be assessing the spelling also. So say, for example, if you're going to write, cesarean section, you have to write not CS. Don't use abbreviation. You have to use, don't use CS like cesarean section. No, you have to cesarean section. Then you have to, the spelling is important when it comes to the medical terms. If the spellings are not good, then the marks will not be allocated. There will be reduction of mark for bad spelling mistakes, right? Especially for medical terms. As far as medical terms, you have to have proper handwriting as well as handwriting. But the person who is going to read it should be very clear enough. Okay, so pay attention on your medical terms, the spellings, as well as the proper clear handwriting when it comes to OSCEs. Those things also will be matter in when it comes to this thing. And what I'm going to do is in coming future, near future, right? When we start the course properly, right? We'll be doing, if you take for a week for about 1 or 2 sessions, I'll be doing free of charge for you all. We'll meet with a Zoom like this, and I will take 1 student, and we will do a live, OSCE station live, right? Then you will get more familiar with this procedure and the process. Okay, clear, right? So any problems so far, Daruni? And closer to your exam, we'll be doing some practical stations near Colombo, so you can join and you can practice as it is in the real exam, right? So that we will arrange closer to your exam, right? Okay, so unfortunately, last night my the laptop went totally blank. So I'm using with this tablet and doing this class. So I don't have proper gadgets at the moment. So we'll be for an initiation, for an introduction, we will do a simple ASCII today. and just to, give some idea about how this OSCE runs and OSCE, how does it works like. Okay. So they will be given we will take one scenario, right? Hope you all can you see the whiteboard? Is that clear? I'm really sorry. Yes, good. We will take a scenario, right? Like this. I'll just switch on. Right. The board is now better, right? So we take a scenario. She's 18 years old. Can you all see? I mean, you don't have to see all these things. Just you can write down in a piece of paper if you want, right? 18 years old, primary mother. 18 years old primary mother. Came at 32 weeks. Came at 32 weeks for the routine antenatal follow-up to the clinic. She is coming to the clinic. So the scenario is 18 years old, primary mother. At 32 weeks, she's coming to the clinic, coming to antenatal clinic for the routine checkups, right? And the booking BMI was 28. Booking BMI was 28. She was previously healthy, and in the clinic, you have checked the blood pressure, and the blood pressure was 160 over 110. 160 over 110, and she is having ankle edema. Significant ankle edema, no other symptoms. No other symptoms. I'm sorry, we'll be doing in a proper way, with a properly written. I will be given the OSCE to you all, right, to get the printouts and all. This is just introduction, so I'm just giving this information. Sorry about the quality and all. We'll do it properly from next week onwards. So the scenario is she's 18 years old girl, 18 years old primary mother at 32 weeks. Coming to the routine antenatal clinic, she doesn't have any complaints, right? Her blood pressure was found very high, and she's having significant ankle edema. Okay. She was previously healthy. They will say she was previously healthy. So the first question then, after this scenario, the scenario will be given like this. They will be asking the first question, what is your tentative diagnosis? What is your tentative diagnosis? She had just had one reading of 160, 110 at 32 weeks. Previously healthy patient.
Preeclampsia.
Okay, preeclampsia. So your tentative diagnosis is preeclampsia. Okay. Can you say this is preeclampsia because you are having just one value? Having just one value, can you say this is hypertension or preeclampsia or something?
No, sir.
Usually, the definition of hypertension or preeclampsia or whatever it is, blood pressure more than 140 over 90 in 2 or more occasions, 3 to 4 hours apart. Does this patient fulfill those criteria to say this is hypertension? Yes, Angela.
No, not yet.
Not yet. So can you say this is hypertension in pregnancy or preeclampsia in pregnancy? They haven't mentioned anything about urine albumin no entry. Just edema, they are blood pressures. Can you say this is hypertension in pregnancy?
Not sure,
Yes,
sir.
sir. Yes, still you can say. This is, if the blood pressure is more than 160 over 110, even one reading is enough to say this is hypertension. That's you have to understand. If the blood pressure is below like 150, 90, 150, 100, something like that, then you need to have two values to say this is preeclampsia or hypertension in pregnancy. But when you have blood pressure of this height, or 160 or 110, even just one value is enough to say this is preeclampsia or hypertension in pregnancy. So your tentative diagnosis would be hypertension in pregnancy, most probably preeclampsia. So your diagnosis, tentative diagnosis would be hypertension in pregnancy, most probably preeclampsia. Then the second question, the format, the second question they will ask, what factors favored your diagnosis? Your diagnosis is preeclampsia, most probably preeclampsia. So what factors favored the diagnosis of preeclampsia? They will give 1, 2, 3 like that. What are they, in other words, what are the risk factors for this girl or lady to have preeclampsia?
So high
Why you
BM.
say this is, yeah, why you say this is preeclampsia? Because of these things. What are the things?
She's high BMI.
One thing is age, Daru. She's teenage. Being a teenage, is it a risk factor for preeclampsia? Sachit? Yes.
Yes.
Extremes of age, revise your theory. Extremes of age is a risk factor for preeclampsia. Either teenage or elderly mothers, elderly fathers. Okay. So age-wise, she is under risk. What else? Being a primey, is it a risk factor for preeclampsia? Yes. Yes. Primey is another risk factor for preeclampsia. Teenage primey. What else? High BMI.
High BMI.
BMI is 28. Okay. What other things? What other risk factors? Or what other factors for you to favor for your diagnosis? The patient says she was previously healthy, so unlike this is chronic hypertension, and she's developing blood pressure at 32 weeks. So previously healthy patient developing blood pressure in the second trimester onwards, again favor the diagnosis of hypertension in pregnancy. So all these factors or factors favor your diagnosis. That is the second question they ask. The third question they will ask, what will you do next? The patient came to your clinic, she's 32 weeks. You detected very high blood pressure and significant ankle edema. What will you do next?
Admit the patient.
Very good. That should be your answer. You must admit this patient to the ward because you can't manage this patient as an outpatient or in the clinic setup. You must admit this patient. Admission is a must. You can't do anything else. You can't proceed with the management, monitoring anything in the clinic. So you must admit the patient's step. Then and there, you must admit. That is your next step. Okay. After admitting, they will ask, they will ask, okay, next, what are the impending symptoms of eclampsia? What are the impending symptoms of eclampsia? They will ask, list 5 impending symptoms of eclampsia. So you have to do 1, 2, 3, 4, 5, like that.
Headache.
Starting from top, yes. Headache. What next?
Visual disturbance.
Visual disturbances like, blurring, flashes, floaters, lightning, those things, right? Headache, visual disturbances.
Abdominal pain.
Before the abdomen, your mouth comes. Nausea and vomiting, especially vomiting. Okay, headache, visual disturbances, vomiting. What next? Then come to the abdomen. So when you are reading, when you are studying also, don't try to buy hard things, right? Try to remember things in a methodical way, starting from top. Headache, yes, good. Visual disturbances, nausea and vomiting. When you come down, neck, nothing, breast, nothing. When you come down to the epigastrium, epigastric core-right hypochondrial pain is very significant because of the liver involvement. Epigastric core-right hypochondrial pain. When you come down, what is next? Exaggerated reflexes with clonus. Exaggerated reflexes with clonus. Those are the signs and symptoms of impending eclampsia. Okay, the scenario was given. Like the you can just have a look, have an idea. I will be doing these things again. As an introduction, I'm just doing this case, right? So they will be given a scenario, like it will be written on your piece of paper, like 18 years old, primary mother, the booking BMI was 28, at previously healthy, and she's coming at 32 weeks for the routine clinic follow-up. In the clinic, you have found that blood pressure is raised and ankle edema. What is your tentative diagnosis? So your tentative diagnosis is hypertension in pregnancy, most probably preeclampsia. What favored your diagnosis? Being a primate, being a teenage primate, and high BMI, previously healthy but developing blood pressure after in the second trimester or 20 weeks, after 20 weeks developing high blood pressure. So all these features are in favor of hypertension and most probably preeclampsia. So what is the next step? Admit the patient. Then they will ask, okay, after admission, so you have to get the full detailed assessment. There you should know what are the impending symptoms of preeclampsia. Starting from top, headache, visual disturbances, nausea and vomiting, epigastric pain or right hypochondrial pain, exaggerated reflexes with clonus. Okay, right? Then they will ask what investigations you will perform on this patient. What investigations you will be doing in this patient. Tell me, what investigations you will do on this patient? What is the first investigation you will do?
Dipstick.
Huh?
Urine dipstick.
Yeah, that's called urine ward test. Urine ward test. What are the investigations you will do, Daru? You take a sample of urine and you check in the ward. There are two ways that you can do urine ward test. The newest way, you have dipsticks, right? There are the calibrated sticks like urine ECG strip, right? You just put into the urine sample and they will give you whether there is protein, whether it is 1+, 2+, 3+, like you can get a grade. That is the newest way. What was the olden way, good olden days, how they did? The strips came very recent for about 1 or 2 years ago. But before, how they did urine ward test? You take a sample of urine into a test tube, right? This can be questioned in the exam. How to do urine ward test in the conventional way. You take a test tube and fill with urine about 2/3. Take a Bunsen burner or even a candle and boil this urine sample. Okay? If you see a turbid, what can this be? If there is no protein, the urine sample, even after boiling, urine sample will be clear. If there's a turbidity or a precipitate or a turbidity, what does that mean? There can be protein or there can be phosphate. If you see a turbidity or a precipitate, either it should be protein or either should be phosphate. How will you differentiate phosphate from this protein? You add few drops of acetic acid. When you add acetic acid, if it is phosphate, it will dissolve. If it is protein, it will be remaining. That's how you do urine ward test. This can be questioned definitely. To get a preeclamptic patient, they will definitely ask, how will you do the urine ward test for protein? Because most of you, right, will not get, tertiary care centers in Colombo or Kandy or Gold, right? So most of you all have to, even after internship, you will have to go far away places like, Pudukkudiyiruppu, somewhere. Pudukkudiyiruppu also not that far. Muladdivu, Pudukkudiyiruppu, Tittapanjala. Where's Tittapanjala? It's not that far. It's closer to Katukastura, right? So there will be peripheral places where you don't have these strips to check the urine protein. So you have to use this good ordered days method. Take a test tube, 2/3 of urine, right? Then boil it. If you see a precipitate or a turbid, add some acid, right? Acetic acid or something, few drops. If the turbidity disappears or the precipitate disappears, that means it was phosphate, not protein. If it is persisting, that is protein. Then how you grade this? Whether it's just a trace, 1 plus, 2 plus, 3 plus, like that. Suppose there is a turbidity. Suppose this is the test tube. You take the test tube on your hand and keep a newspaper or something, some paper with letters and all, not with pictures, but with letters, right? Take that paper behind the test tube and you try to read it through the test tube. You got my point, right? You keep a piece of newspaper behind and keep the test tube in front of you and in between the you and the paper, and you try to read the letters through that test tube. Test tube, you have water and urine, no? So through that urine, you try to read it. Okay. If it is just trace, you should be able to read the letters with some difficulty. It's trace amount of protein. If it is 1 plus, you will be able to see some letters behind, but you can't differentiate whether this is A, this is B or C or whatever. What are the letters? You can see there are some letters, but you can't read them. When it's come to stage the albumin 2 pluses, then you can't see anything. I mean, there will be some markings and all, but you can't appreciate those are letters even. When it's come to 3 plus, you can't see anything. It's a thick whitish precipitate, like solidified, so you can't see anything behind the test tube. So something like that, trace 1 plus, 2 plus, 3 plus, you can grade it. This is called urine wart test. This is one of the things that you should know when it comes to the Osce's, definitely. And okay, this is the way to do urine wart test for protein. So what were the questions they asked? What is your tentative diagnosis? What factors favored your diagnosis, right? Then what will you do next? You have to admit the patient, and what investigation, what are the impending symptoms of eclampsia? And then they will ask, okay, what are the investigations that you have to do? You must do, first of all, urine wart test. What other investigations you have to perform on this patient? Patient's blood pressure is very high, right? Thirst too big, edema. So what are the investigations you have to do?
Renal function test and liver function test.
Okay, yeah. You can start doing full blood count. What is the purpose of doing a full blood count?
Thrombocytopenia.
Very good. Thrombocytopenia. Why thrombocytopenia, Rose Sagaya?
Because I think the patient's at risk of DIC.
Is it DNC? Is it because of DNC you are doing this thing or something else? HELP syndrome. Is she at risk of developing going into a HELP syndrome? Yes. So by doing a full blood count, you can see the platelet count. Okay, whether the platelet is low or not. Because especially full blood count is a must, because if you happen to deliver this patient going for a cesarean section, you must know the platelet count. So you must do a platelet count because she's at risk of HELP syndrome. And meantime, you can assess the hemoglobin level also. So do a full blood count. What are the investigations? Yes, as you mentioned, renal function test. What are renal function tests? Serum creatinine, blood urea, serum electrolytes. Why you want to do those renal assessment? Because preeclampsia can shut down the kidneys. It's a multi-organ failure. So you have to assess each and every organ system. So do a full blood count to see the platelet and hemoglobin, do renal function tests, and do liver enzymes and liver function tests. ASTAT you have to do, and also to assess the liver function, you have to do INR, PT-INR. Because preeclampsia itself can derange your coagulation. So you have to assess the INR. And when the liver is damaged, the chance that INR is going up is high. So you must do it. So you have to do a full blood count, so the platelet count and hemoglobin, renal function test, liver function test, and INR to assess the coagulation system. These are the investigations we do routinely in the patient with preeclampsia. Urine blood test and these blood tests. Okay. And if they will say, now this is the basic workout, then they can move on to the next step. Then they will change the scenario, like, or they will proceed with the scenario. They will say, okay, after admission, the patient's blood pressure remaining same. After admission, blood pressure remaining same, and albumin 2 pluses. Albumin 2 pluses. What drugs you will be given for this patient? Her blood pressure is high, and also urine albumin 2 pluses, and she is having edema.
IV
What drug? Yes. So before going into IV labetalol, you can try oral nifedipine. Nifedipine is very effective. What are the emergency antihypertensive drugs that you can give in this kind of a scenario? Nifedipine is usually first line. You can give oral labetalol. If it is not responding, go for IV labetalol and hydralazine. Those are the 3 drugs that can be used in these kind of patients. Do you use methydopa? No, no point of you starting methydopa because it doesn't control the blood pressure that fast. It will take about 1 or 2 days to bring down the blood pressure. So methydopa does not come under this patient. It's nifedipine, you give nifedipine, and you can wait for about 15 to 20 minutes and check the blood pressure again. And if it is not responding, you can even repeat nifedipine and you can go for labetalol. Nifedipine and labetalol are the first line drugs for these kind of patients. If the blood pressure cannot be controlled with oral labetalol, you have to go for IV labetalol. What is the biggest problem with hydralazine? What is the biggest problem with hydralazine?
It drops the blood pressure very fast.
Yes, very good, Chaitya. It drops the blood pressure suddenly, fast. You know, in a preeclampsia, whether you all can, I don't know whether you can remember on pathophysiology, this high blood pressure is not the problem actually. High blood pressure is essential for the perfusion of the baby. Because there is a problem with the arterial at the placental level. To overcome that resistance, mother increase the blood pressure. If you drop the blood pressure suddenly, the baby will not get any supply. That can lead to IUD. So if you are bringing down the blood pressure, it should be gradual, not drastic. One of the problem with hydralazine is it can drop your blood pressure drastically. Okay, Dinelli? Right? Right, okay. Noodles right? So it may drop the blood pressure drastically. That is not good for a hypertensive mother. Okay, right. Is that clear, Daru? So you can give oral nifedipine, you can give oral labetalol. If not responding, go for hydralazine. And this is the first line. I mean, this is when the patient is in the ward, when the blood pressure is high. These are the drugs we started with. But what is the drug of choice for this patient? Blood pressure is very high, persistently high, albumin 2 pluses. What is the drug of choice? Mag sulfate is the drug of choice because having this high blood pressure, she can go into eclamptic state. Usually, if the blood pressure can be controlled with nifedipine or labetalol without impending symptoms, You don't have to start metsulfate at once. But if the blood pressure cannot be controlled, or if the patient is having any impending symptoms like headache, visual disturbance, or so anything, exaggerate reflexes, you must start metsulfate. Starting metsulfate, it takes some time because you have to prepare that thing. You have to, not like nifedipine or nifedipine. You can ask the patient, okay, take this tablet, swallow this tablet. But metsulfate has to be prepared, and you have to connect it to a burette set infusion pump, and it will take some time. So you initially start with nifedipine and labetalol and see whether you can bring down the blood pressure. If the blood pressure is not controlled, start metsulfate. Or if the patient is having any impending symptoms of eclampsia, straight away start metsulfate. What is the dose? These doses you should know, because in obs and gynae, only few drugs that you have to know the dose. That is 4-gram bolus followed by 1 gram per hour infusion. Okay. What are the benefits as far as the neonate or the fetus is concerned? What are the benefits to the baby when you start metsulfate at this PUA?
Neuroprotective.
Neuroprotective. Up to 34 weeks, you have to give a metsulfate that controls the preeclampsia part as well as it's beneficial to the baby as a neuroprotective effect. So both ways it is effective. So if you start metsulfate, what are the things that you have to monitor? What are the 3 main complications of metsulfate? Just give me 1 second. Yes. What are the 3 main complications or risk factors or complications of metsulfate? It is cardiotoxic, respiratory toxic, and nephrotoxic. Cardio, respiratory, and nephrotoxic. So if you're going to start metsulfate, you have to monitor the cardiac status with blood pressure, pulse rate, and if you have ECG monitoring, you have to monitor with ECG. Okay, respiratory system, respiratory rate and the saturation. Renal system, you have to check with hourly urine output monitoring. If you start metsulfate, right, usually you have to deliver this baby within 24 hours. At 32 weeks, primary mother, likely that her os is going to be close, or the cervix is, or the Bishop's score is low. So most of the cases, you have to prepare this patient for a cesarean section. Okay, so you have to prepare this patient for a pregnancy. What other drugs that you have to recommend to improve the overall outcome of this pregnancy? Now you have given nifedipine plus or minus labetalol and metsulfate. What other drugs necessary? Sachin, Sankar, what other drugs necessary in this case? What about dexamethasone? Will you recommend dexamethasone? Yes, she's still 32 weeks. So giving dexamethasone can minimize the risk of respiratory distress in case if you happen to deliver this baby. Okay. In the meantime, they can ask, right, other questions. How are you? What are the pre-operative preparation for a cesarean section? What investigations do you have to have for a cesarean section? Only the full blood count. Since she is young, less than 35 years, you don't need ECGs and all, right? Just full blood count is enough. Since you have already done full blood count in the assessment, you don't have to do it again. So investigations wise, only full blood count. To reduce the gastric acidity, you have to give pre-medication drugs. What are those? IV ranitidine, IV metoclopramide. To reduce the gastric acidity and thereby the aspiration. So send a full blood count, trace your full blood count, start pre-medication drugs with IV ranitidine and IV metoclopramide. If you're going for a cesarean section, how many bloods need to be cross-matched? For a cesarean section like this, how many blood points you have to cross-match?
3.
One enough. Just one enough. If this is a preeclamptic patient or if this is a patient with fibroid complicated pregnancy or any risk of PPH, then you have to have 3 or more. But usually for any cesarean section, no, not otherwise complicated, just 1 pint of blood is enough. What is the problem of cross-matching more pints of blood more than the necessary? Because it's costly. To cross-match 1 pint of blood, it takes a lot of time and money. So you don't cross-match blood unnecessarily. Okay. 1 pint of blood, full blood count, pre-medication with IV ranitidine and Maxolon. Okay. What next? Shaving. You have to shave the patient before you send the patient to the theater, just before sending to the theater, shaving, catheterization, and one of the most important thing is informed written consent you have to take. Informed written consent should come first. Informed written consent, full blood count, cross-match 1 pint of blood, IV ranitidine Maxolon, shaving, and before you catheterization, and before you send the patient to the theater, another important check that you have to do. What is that? Now you prepared everything, patient consented and catheterized, shaving and everything done. Blood is ready in the blood bank, hemoglobin available. Now you are ready to send this patient to the theater. What other important thing you have to do before you send to the theater?
The anesthesia and pediatrician consultation.
Okay, yeah, you have to inform them. Yes, you have to inform the pediatric team and the anesthetic team. What are the important check that you have to do? WHO checklist. You have to fulfill or you have to take the WHO checklist before you send the patient to the theater. It's very important. Once the patient reaches to the theater also, they will receive the theater, they will check WHO checklist again. But before you send the patient to the theater, make sure WHO checklist is done, completed. Okay. They will ask, okay, after delivering of this baby, for the future, is she having a risk of preeclampsia, developing preeclampsia in near future, in next pregnancies, following pregnancies? Yes. What are the preventive measures that you can do in future pregnancies to minimize the risk of preeclampsia?
Aspirin, low dose
Yes. Yeah, you have to start low dose of aspirin when?
12 weeks.
12 weeks onwards in next pregnancy. Very good. From 12 weeks onwards, you have to start aspirin, low dose of aspirin. 75, some people start 75, some people start 150, still low dose. 150 or 75 milligrams, you have to start. "12 weeks on." Sorry, I got a call, that's why it's got stuck. Sorry. So from 12 weeks onwards, you have to start aspirin. Right? Any investigation that you can do, I'm just asking for just for interest, may not be asking in your Viva. Any special investigation you can do in her next pregnancy to predict she's developing preeclampsia in future? Any special investigation that you can do in next pregnancy to predict she's going into preeclampsia?
Uterine artery Doppler.
Very good. Uterine artery Doppler. Very good. Well done. If you do the uterine artery Doppler around 14, 15, 16 weeks, if the uterine artery Doppler shows high resistance, that means she is having a risk of developing preeclampsia in future. What else came here? Is it only preeclampsia? IUGR,
Yeah.
preeclampsia, placental abruption. All 3 complication risk is high if the uterine artery Doppler, not umbilical artery, that is uterine artery, the uterine artery on either side, uterine artery Doppler. If you do it, And if it shows high resistance, then that predicts patient is going into preeclampsia in future. Good. Okay, right. And in the same OSCE station, sometimes they might show max sulfate vial for you all to identify this is max sulfate, right? And those things also can be given. So basically, same thing that you have learned, but they will be asking in a stepwise manner, in a methodical manner, the questions, practical as well as some theory questions related to that particular scenario. Okay, Daru, is that clear? And this is how the OSCE runs. I'll be doing in a proper way, right, with the printed notes and all, right? Proper way we'll be doing how to do these OSCE stations, right? It will be easy, don't worry, right? It will be much easier. It will be much easier than the good old days examination pattern, like with real patients taking histories and all. This is going to be less stressful as well as they can assess the level of knowledge of the students, but ultimately, when you are not used to that typical history taking and all, when it comes to the when your internship starts, sometimes you might feel difficulties with managing patients because you don't know how to talk with the patient, you don't know how to do the proper examinations and all. Taking histories and is going to be difficult. So these difficulties will be coming in the future. But for the exam point of view, this is the most important thing at this point. For the exam point of view, OSCEs would be better than your good order days examinations. Okay, clear, right? So, so don't worry that we'll be doing these OSCEs again and again, right? I'll be doing 3 sessions for you all also, right? And you will be confident in doing these things when you come to the exam. So my advice is that, right? Please go through your theory notes, revise. Okay, revise the theory because that is important. Now, when it was come to the previous examination pattern, right? Like with real patients and all, long cases, the examiners will not ask theory questions usually. They will be asking few practical questions. But when it comes to OSCE, sometimes your theory knowledge also may be assessed again related to that topic. Okay, so refresh your theory, and we'll be starting these classes soon. And then if you want, you can join. You think my teaching pattern is good, you can join, right? The one of the problem that I had recently, I couldn't answer some of the queries of the students. I'm really sorry. I'm trying to answer your queries and clarify your doubts soon as possible in your near future. So that problem will not be coming. Otherwise, we'll be doing these classes, and if you think it's beneficial, you can join, and we'll be doing these OSCEs. You don't have to worry. Okay. If you all have any questions now regarding OSCEs or the thing that we discussed today, the case scenario and all. So I'll be discussing all the procedures like twin delivery, breech deliveries, and then shoulder dystocias, and these things will be demonstrated, right? We'll be doing those things when it comes to the practical sessions, right? So don't worry. And thank you very much for joining today. I'm really sorry about the setup, and because I couldn't do it proper way because my laptop was stuck halfway. So we'll be doing it in a proper way from next week onwards, right? Thank you very much for joining. And if you all have doubts, you can contact me, and you can contact Subir also. Right? Thank you very much. Have a nice day.